the outset, and this actually, Dr. Ashish Bashir titled this, How to Correctly Approach a Patient in the OPD with Sinonasal Tumors. Now, I'm the last person you should ask to approach anyone correctly. You just need to ask my wife. She'll probably have her views on that. But having said that, I think sometimes it works if you think laterally as well. So I'll just talk about the role of imaging in nasal tumors. Brief overview of what I'm going to. After introducing, we discuss why imaging is required, what are the modalities, features, CT features, because if you're talking about radiology and we do not talk about features, I think there's no point, the role of MRI, and finally the approach to the patient. Well, the reason why we need imaging is that it aids in the diagnosis, staging, surgical planning, so on. But one must not forget that this is not the first part of approaching a patient. We have to go through the entire lot. Just like we were taught in clinical examination, in our clinics, the first and foremost thing is history. So little things like duration, whether it's one-sided or bilateral, whether there is bleeding or not, and whether there are any associated symptoms which we shall briefly mention later, whether those are there, that will direct us to a logical way of thinking about the pathology at hand. This is followed by clinical examination and clinical examination of the face, the head and neck region, and which moves on to endoscopy. Endoscopy today is a part of a clinical examination really, because you cannot examine the nose properly without using the endoscope. So I actually include it as a part of my clinical examination. You may or may not bill the patient for the private practitioners here for that, but the point is, if you miss a pathology, I think that is something that you would regret later on. So I think it's worthwhile to do endoscopy in each and every case where you are suspecting a nasal pathology. After that, of course, imaging, and after you've done the imaging, biopsy, because nothing we can do without having a firm diagnosis on biopsy. So why are we talking about all this about imaging? Why do we need to image? The thing is, the fact of the matter is, whether it is a simple DNS or somebody having allergies, they could all present with very similar and aggressive tumor. The presentation may all be the same. So the very non-specific symptoms, like we've talked about, what is relevant, of course, is the red flag symptoms, which we all know. And even when we are examining them, a lot of lesions appear to be polyps. They are all polypoidal in nature. Some of them may have even polyps when they are exposed to the outside environment. They can develop secondary changes because of exposure. You have keratosis on polyps also. So even a simple polyp can look like a tumor, and a tumor can look like a polyp. So that is why with the common presentation, it's important to image. They obviously suggest diagnosis because there are certain features which are supposedly characteristic. Having said that, you don't go just by the features on imaging, because most of us have actually burnt our fingers in this, thinking that this is that tumor because of that characteristic image finding, but it turns out to be something else. Of course, we have to know what is the extent. As we know, the nose and paranasal sinuses are all hidden to us. So without imaging, we cannot know the extent. And for a surgeon, very importantly, when we are taking up for surgery, we would not want to know the landmarks and what all is involved. We can distinguish between, there are certain pointers, we cannot distinguish, but there are certain pointers whether to distinguish between benign versus malignant. And when we include even things like PET, CT, then we do metastatic assessment. Staging, of course, can be done by just regular cross-sectional imaging, but for metastatic assessment, you would do PET CT as well. And of course, you would need this to monitor response and detect recurrences. So what are the modalities? We all know the modalities of imaging, and we are not going to go through all of them. But as everyone knows, CTs are better for bone, MR for soft tissue. I mean, this is a no-brainer. But yes, so the strengths and limitations have been listed here. This is something that I was supposed to speak the last, but I thought it's important because before we are embarking on imaging, what is our thought process going to be? So whenever there is a unilateral lesion, there is something suspicious in the appearance, there are associated signs and symptoms, we can proceed directly to imaging. However, a lot of these patients that you get with nasal symptoms, where you've seen what is otherwise classical polyposis and or chronic rhinosinusitis even without polyposis, if you want to image, do so only after the medical management. Because more often than not, one sees patients who have just presented and the practitioner has asked for imaging immediately. It's not a very useful modality for, say, something like chronic rhinosinusitis. So we talked about the appearance. So all the F's, anything fleshy, friable or freaky, which is basically anything that is other than what looks like a classical polyp, your suspicion gets aroused, and things, associated symptoms like that of involvement of the eye with either proptosis or even restricted mobility, other cranial nerve palsies, or altered sensation on the face, which is also a cranial nerve palsy, facial swelling or painless falling of teeth. Again, these are the red flag signs that I was talking about. So now comes to the what modality would you choose? Usually, as a first line, the paranasal sinus CT is the first line imaging modality that one would choose. You will notice I have written CECT and not plain CT PNS. Now, plain CT PNS, if you are thinking in terms of chronic rhinosinusitis or simply polyposis, nasal sinusitis, CRS with polyposis, you would do a plain CT. That is good enough. However, when we are talking about, today's topic is about tumors. So if you're talking about any of the suspicious lesions, you would want a contrast, ideally. There are limitations. Patients' creatinine may be high and you cannot do the contrast, so you have to compromise, but otherwise CECT is what you would ask for. It's done very fast, it is much cheaper than MRI, and it gives you fairly good bony landmarks, which for a surgeon that is very important. So you would want that in any case. The other thing that I would like to mention is, if this is a tumor that we are talking about, you might as well ask for a CT, which if you have a neuronavigation or you're following navigation protocols, you might as well get this done now. Time and again, one has encountered this. You get a CECT done, that is just above the eyebrow, and that is not good enough for registering your navigation system. So if your institution, you're doing navigation, and then what happens is you've exposed a patient to a CT, to the radiation from CT. After 2 weeks or within a week also, sometimes you are subjecting them to another CT scan because you want to use navigation. So again, when we are talking about tumors, this is entirely up to the institution that you are in. If you're using navigation, you might as well do the navigation protocol because it doesn't offer too much of extra radiation. The part that it is irradiating is the part which can do without radiation. Actually, the most sensitive part, that's the eyeball, that is getting radiated anyway. And the neck, when it comes to the neck, yes, that's another sensitive area, but that would be, again, that's being covered in the paranasal sinus. So what are we missing out on? Just do the part. If you got that, do it. Now this is usually followed or complemented by MRI, again with contrast. We are talking about lesions which may be neoplastic, so we would like to know the enhancement and involvement of its periphery. Hence, MRI with contrast would become essential. Gives very good soft tissue details, can help us differentiate between neoplasm and inflammation, intracranial spread, neural involvement. So whenever you are evaluating a patient, you would like to have both these modalities, and ideally, even though your radiologist may be very good, I think it's time that we as ENT surgeons actually started looking at the DICOM images ourselves, because whenever we are going to do surgery, you have, by the very fact that you have seen the DICOM images, you've got a three-dimensional map in your head for that particular patient. So it is very helpful, and you'd be surprised how many times radiologists miss out. Not because they can't see, but because they feel it was not relevant. Whereas for a surgeon, that may be a very relevant thing. Now, I'm going to be talking about the patterns of bony involvement, each in detail, in slight detail, not too much, because again, each one is a heading by itself for a full-blown. So, bony erosion basically implies aggressive disease. We see this in malignancy or osteomyelitis, but also in invasive sinusitis and certain granulomatous diseases. Interesting, the granulomatous diseases tend to be more central as compared to being lateral, whereas the others, of course, are all over the place. The next part is reactive sclerosis. So any indolent process actually sets up an inflammatory response. So the periosteum of the sinus involved can lay down bone over a period of time. So when you see a thickening, you actually get asymmetry on the sides, which will give you a pointer that this has been going on for some time. It is not the cognitive of anything, but it just tells us that the process has been going on for a while. This is a slide where point here showing an inverted papilloma with not only thickening of the sinus, you also see the characteristic neo-osteogenesis. Well, I can just walk up to it. That's much simpler. So, bone remodeling we see when it is really long standing and there is an expensile lesion. So, Again, this can be seen in things like mucocele or inverted papilloma, and simply it reflects that it is a slow-growing neoplasm. It is again not a tumor. Fibromuscular lesions, I've just included these because they are very common. Frontoethmoid region, especially frontal sinus osteomas, are fairly common that you encounter. And here you see the classical lesion. And in fact, in this slide, in this cut, you can see the retained secretions above that same. This is the same patient. Incidentally, I have taken the images from the internet, but these are not downloaded off the internet. These are just data sets which are available. So you have to actually painstakingly go through the entire data set, select the image. These are just raw and anonymized data sets where you can get the images of the internet. You can look for any pathology, and go through all the sections just like you would any other CT or MRI scan.
And what about the lacrimal set, right, left?
So the lacrimal set on the left side, that is absolutely fine in this case, sir. This is absolutely normal in this case.
And right and left is the difference.
The retained secretions are in the frontal only. This is or rather the supraorbital. I have included this one very specifically. Fibrous dysplasia, this is the one condition where you cannot rely on an MRI. MRI can throw you off completely because the fibrous dysplasia has a tendency to have a very varied appearance on the MRI. It can appear as a very destructive lesion. It can have various kinds of changes, whereas the CT scan, in fact, just one look at the CT scan and the ground glass appearance that you get in a fibrous dysplasia is characteristic that would give you a diagnosis.
I think, sir, this is not a fibrous dysplasia, it is an ossifying fibroma.
So these are confirmed, histologically proven
This
cases.
is not a classical ground glass appearance. Ground glass appearance will be like the whole bone will be, it will be a bony round lesion.
Right, but fibrous dysplasia, sir, it's a spectrum. It is not just one. That is the reason why MRIs are not used for fibrous dysplasias. Fibrous dysplasias can be
difference in the fibrous dysplasia and the ossifying fibroma or cementifying ossifying fibroma is that in cementifying or ossifying fibroma, you will have a bony outline with a lesion, with a soft tissue lesion inside. But a fibrous dysplasia will be absolutely ground glass appearance, and that is why we actually do shaving in fibrous dysplasia, but we have to do a maxillectomy in ossifying fibroma.
I agree with
this. For example, in this patient, you need to do a maxillectomy, not a shaving. You can't do a shaving in this.
If you notice, I didn't go into these details. This is a histologically proven fibrous dysplasia, and you see these plates. These are plates these are titanium plates which have been placed after the shaving, and I have only taken cases which are histologically proven. But yes, I completely agree with you. The classical. This is not that. See, in a ground glass you get a complete.
Yes.
It is a completely homogeneous appearance, which I completely agree with you. But again, like I said, this is a histologically proven case, which is why I cannot contest it. That's why imaging can be fallacious. The final word is always with the pathologist. So just appearance can be sometimes deceptive. Again, and this is a bit of a teaser actually, this presentation. It cannot be comprehensive in terms of the varying spectrum of each pathology. So you can, these are the things that you would look for in an MRI. And we can actually talk, when we come to MRI, now MRI is vast. We can talk about the changes that we see on T1, we can see on T2, the stir images, fat suppression, then with contrast, without contrast. So it becomes actually, since we are talking, I'm not a radiologist and I'm not talking to radiologists or not covering those aspects. However, this is something that we're all familiar with. We've got a tumor which on a CT scan looks like it has broken through the posterior wall of the maxillary sinus, but when one actually sees the MRI, you can see that that is actually just inflammatory trap secretions, which has led to the expansion and bony erosion posteriorly. Dural involvement, extensive. There is extensive data now. Previously, it was considered 5 millimeters, greater than 5 millimeters they used to take. Now they say that 2 millimeter thickness of dural thickening that you see, especially if you've got nodular dural enhancement, and there is a loss of the hypointense zone, that would be what would suggest dural involvement. As you can see in the CT scan, one cannot make out the difference between the tumor and the brain really. Whereas on an MRI scan, you actually have a clear cut. There is no bony. We can say that there is no dural involvement because of this clear zone that one can see between the tumor and the dura and the brain. Sorry? Yeah, but it will be another couple of minutes. So similarly for the orbital involvement, inverted papilloma is, well, another, I think somebody is talking about inverted papilloma specifically. Characteristic things are the hyperostosis as well as the cerebrum, CCP, that's a convoluted cerebriform pattern, as you can see very well in this slide. Now, I'll just talk about this was a slide which I added because Dr. Ashish asked me to. Obviously, it all depends on the infrastructure that you have and your personal experience. But as I said, the most important aspect is that the basic principles of following history, clinical examination, endoscopy, imaging, these steps have to be done before you embark on taking a biopsy. Even if it is a small biopsy, if you want to take it in the outpatient, be very clear that you have all the infrastructure to handle if things go south. Why is it very important? Because nowadays, what the last bit I've just added, because nowadays it's not enough to just take a biopsy. You have molecular biology of the tumors actually give you fairly good ideas. Previously, we were happy on saying, okay, this is squamous cell carcinoma, keratinizing or non-keratinizing on the basis of morphology alone. Today, they would like to do molecular biology, not available everywhere, but those are the guidelines that they've encouraged you to go through molecular biologies. Just like I talked about, SNUC is like a death sentence. But if you've got IDH2 mutation, the prognosis is pretty good, even with SNUC. So if you know that you have that, your the whole outlook to life changes. With that, I'll just talk about somebody interested in SINO-NASAL malignancies. There's a reference I've given here. This is available. It's a freely available source. and very comprehensive, beautiful text for these guidelines are very current, the latest guideline, and they're quite comprehensive. With that, I think I'll end this. I don't want to cover all the other. That's the kind of the tumors that we are talking about. We don't want to be talking about that. Far beyond my pay grade. So
One
with
question
that,
before you end is regarding again biopsy. So apart from the fact that one has an infrastructure which can manage bleeding or no bleeding, are there other considerations which you want to have a biopsy, which is a surgical biopsy? By surgical, I don't mean cutting the skin into the operating room.
Right.
Or are you comfortable biopsying in your outpatient,
Okay.
even if you have the resources?
Given that there's another aspect of taking the biopsy, that is, supposing you've got a patient who's got a nasal mass and you just pluck out whatever you are seeing right in front of you. What happens is that this could be non-representative. So it's very important wherever there is where you think that you're unable to take and this imaging helps us with that, because you'll find the tumor area is in the depth. You do need to go through all that to get that tumor. Otherwise, what will happen is that you've taken a little biopsy from the outside, and even if you're doing a surgery, you've used a microdebrider and pushed it inside. So the tumor part actually goes into the microdebrider, whereas the polyp, what looks like which are just some edema and some mucosal changes which are above that, the secondary sinusitis changes, you just plugged that for a biopsy and left the tumor. So that can be, of course, a disaster. So it's very important that you actually, in an ideal world, every case would go to the OT, but it's not always possible. Sometimes you can make decisions on the basis of overall picture as well.
Can I add a comment?
Yes, sir, please.
So basically, when you have a nasal sinonasal mass, open biopsy should be avoided. You should not be doing any calculus.
Yes.
It should be endoscopic target biopsy. CT or radiology must be there before you take the biopsy. That's very, very important, because
Absolutely.
sometimes there can be a tumor which is connected to the intracranial cavity and you take a biopsy, patient has a C-cell anorrhea, or you have a tumor which is very, very vascular, which will be easily picked up on MRI or CT. So enhancement will show that it is a vascular tumor, so you have to be prepared. And as sir has told, very important, sometimes what happens, there are polyps which are anterior to the tumor, right? So because there is an obstruction, there is a tumor which is growing into the ethmoid or into the pancreas sinus, and there is an obstruction to the flow of the secretion. Polyp, the mucosa ahead of the tumor might become very polypoidal. And what you do, if you take a biopsy from the polypoidal mass, it will come as a polyp, not a tumor, right? So that things you have to be very careful about it. And radiology must be preceded by a biopsy. That is very, very important, because it will give you a lot of idea about the tumor characteristic, and then you can easily plan. Another point, multiple biopsies must be taken, because what happens when you have a tumor like inverted papilloma, there are multifocal lesion, right? So there could be lesion where it might be having a malignant change, right? So you have to take a multiple deeper biopsies to get a true picture of the tumor.
Absolutely. In fact, since we've talked about this, there are certain imaging guidelines for changes, carcinomatous changes in an inverted papilloma. You can get some indicators on imaging as well. So I did mention that the focal loss of CCP, some bony erosion, or if there is any extra sinus egress of the then you should be looking at a possible carcinomatous change in a IP. These can be, I think we'll spend more time doing that. So we'll take the photographs.
So this was originally not part of the discussion because we had thought the keep broad based. But I think Moore was not coming, so we had skipped JNA. So the topic, the specific reason for choosing this topic and this particular pathology was that it represents somewhat a grey zone between the benign and not benign lesions. So while we warm up